So I'm going to talk on thin versus thick strut DES today. So since the introduction of stent for the treatment of CAD, there has been continuing efforts to improve the clinical outcome, mainly through reduction in restenosis, need for repeat revascularization, stent-related complication, and incomplete healing and stent thrombosis. So coming to strut thickness, it is defined as ultra thin when it's between 60 to 80. Thinner are the second generation DS from 81 to 100 micron. Thick strut like the first generation DS were typically more than 120 micron thickness, and intermediates are between 100 to 120. So do thinner stent struts improve outcome? So the discussion started since 2001 when this study was published by Dr. Adnan Castrati. And what he compared, this was basically a bare metal study, and it compared a thin versus thick strut BMS. And what he found is restenosis rate was almost double in thick strut stent. It was 14% compared to the 25% in thick strut. And even reintervention required was also quite different, 8.6 versus 13.8%. So which is better? A thick strut, thin strut, ultra thin, or thinner the better? So answer is not that straightforward. So I will like to put forward whatever evidence I came through, and then we'll discuss. So there are definite advantages of thin or ultra thin struts, like lower crimp profile, improved flexibility, better side branch profile, less metal at carina, and bifurcation stenting. And other benefits like risk of acute thrombogenesis remains low, there is lesser trauma, lesser inflammation, minimal flow disturbances, faster endothelization and healing, and which is a basis for a recent trial showing benefit with the reduced duration of DAPT. So this was the meta-analysis published of thick versus thick struts, basically the first generation DS compared to the second generation DS, and it shows it reduced MACE by 18%, MI by 43%, stent thrombosis by almost 46%. And there was trend towards reduction in the rates of TLR and TVR. But is ultra thin better than thin? So this was another meta-analysis published in 2018, and it compared second generation DS with the ultra thin stent DS. And what it showed is there was a 16% modest relative risk reduction in target region failure. And this was another meta-analysis which also showed that TLR risk ratio was 0.85%. But these were the meta-analysis. What head-to-head comparison trials of ultra-thin DES and thin DES shows. So there were the studies like Bioflow 226, which compared ultra-thin sirolimus eluting with second generation urolimus eluting stent, and most shows that these two stents are non-inferior to each other. There was one study which is BioSTEMI, which compared ultra-thin sirolimus eluting stent with second generation urolimus eluting stent in STEMI patient, in which the ultra-thin strut stents fares better than the thin strut. But if you consider a PRISM 4 study, which was in a CTO patient, the late luminal loss and high TLR rates in ultra-thin struts were higher than compared to second generation DES. So, and again, we have to consider when we do a bifurcation lesion, the side branch expansion capacity of the DES. We should know what is the side branch expansion capacity of the different drug-eluting stent, and it can be different in different sizes of the same stent. So we should know which balloon we are using and how much expansion of that stent is done when we use that balloon. So in nutshell, ultra-thin stents are as safe and effective as second generation thin strut stents. Ultra-thin strut stents fares better in some patient subsets such as STEMI. Thin strut stents fares better than ultra-thin in CTO and calcific lesions. Ultra-thin strut stents ease side branch crossing in bifurcation stenting. Thank you.